what we're going to talk about. So the public option was actually a fellowship project, I think, for this guy, Jacob Hacker, when he was a fellow. He came up with it as a thesis statement, fleshed it out, and some of his writing from back then is still the seminal thinking about what this could and should look like. And even back then, he sketched out some of what I'm going to be talking about as the pros and cons. Although, as you can imagine, in the decades since then, the thinking has developed and emerged beyond that. But um, he did do a lot of thought on it. So if you wanted to read foundational stuff, I would tell you to look up Jacob Hacker and look up what he's written on it. So it was growing in popularity, becoming something that people thought about and considered. It was actually baked in to the Affordable Care Act when it was being promulgated as part of the plan to include a version of the public option on the exchanges, the marketplaces that the ACA created. The insurance industry was horrified by the notion of allowing a public option to be included on the marketplace exchanges. And this guy, Senator Joe Lieberman from the state of Connecticut, which is the home of many of the major insurance companies, exerted enough influence over the crafting of the Affordable Care Act that, frankly, had it continued to include a public option, the Affordable Care Act would have not been enacted. It would have not gotten, I think, even out of committee. So Joe Lieberman is credited with having ended that phase of consideration of the public option. But that was 2010, and a lot has happened since then, including Senator Lieberman's passing a couple of years ago or so. So that's where it stood. So it's been controversial ever since its inception by Hacker. Here's something that Hacker wrote in 2021 about the public option in the New England Journal. He said he described it as public insurance through Medicare. And he said that remains the most realistic way to guarantee universal coverage. He said advocates need to lay the groundwork now for universal coverage by improving Medicare and the Affordable Care Act, by establishing the foundations for automatic enrollment for people without alternative coverage. We will unpack that paragraph, although it will take me a few minutes, but we will unpack that paragraph. So he viewed his proposal as foundational to either going to Medicare for all or to just improving Medicare or for part of what the ACA was trying to accomplish. The insurance company didn't like that, industry didn't like that, as I was saying, because they didn't think that they could compete effectively against a publicly run program. So Sally Pipes, a very thoughtful, but in my opinion, very consistently wrong, but really smart voice from a further right point of view, wrote in Forbes magazine about the public option as recently as 2 years ago. And like I said, I disagree with what she says often, but she's really a smart person to consider. You really need to consider things that she says thoughtfully because you can learn some stuff. She said, but this wasn't an example of that. She said Medicare for all and the public option are two paths to the same destination, a government takeover of the health insurance system. Tells you where she's coming from. She said Medicare for all is upfront about wanting to take over the health insurance system, and the public option slouches towards single payer. So I guess I'm proposing that we should slouch towards single payer through the public option, to use Sally Pipe's language. But not everybody would agree that the public option is a pathway to single payer, and indeed PNHP actually does not agree with that, but yet it's characterized. So look at how it's characterized. She's characterizing the public option as the same, really, as the road to Medicare for all. So we'll come back to that point, but here's an example of them being put in a very similar bucket. So what is a public option? It's a publicly run program that would be launched in some way. And the idea that Hacker proposed and that most people talk about it as is putting it on the marketplaces that exist today and having it be another form of health insurance, Have it be sort of a market-driven solution. It's if you put it on the marketplace, if it's better, it'll grow. And it will then take the pathway of consuming all of the health insurance industry. And if it's not well run and it's inferior, it'll die. So it's an additional option, additional way to run health insurance, hopefully better, applying the free market, as I just alluded to. If it's good, it would get us to universal coverage. One of the merits of it is that it would be less disruptive because you wouldn't have to displace anything, right? It's just if it survives and thrives, it'll grow. But you don't just offer it. It doesn't necessarily disrupt the insurance industry. And for that reason, one of the merits of it would be that it's easier to pass a public option than it is to pass Medicare for all. The downsides to it, to trying to enact a public option, are that it's blurred as if it were single payer. And indeed, I showed you one example, but there are many I could show you of the insurance industry, not just Sally Pipes, but the industry running ads aggressively saying single payer, Medicare for all, public option, all these things are going to take away our government takeovers and take away your choice. So indeed, any attempt to improve, to pass a public option would face many of the same opponents as single payer by itself faces. And we know that that's hard. So the point would be, why, if we're going to face that much opposition, why not face opposition for the thing that we really want, which is single payer? Why do this program? Why fight for something that's going to have as much opposition from vested interests and not ultimately get what we want? So that's one of the challenges. Another challenge is that really you think a way forward is to add yet one more choice to the insurance marketplace. It's already a nightmare for patients to try to choose which insurance product they want, either from the ACA marketplace, or for employers to pick, or for Medicare Advantage and all that happy stuff. It's already complicated, and you're just going to add one more choice, which is confusing to patients. That also means one more level of bureaucratic overhead that physicians have to deal with. Now we not only have to have the ability to interface with all of the insurance industry as we have today, now you're going to add yet one more thing that we have to have the infrastructure to interface with. So complexity is not just wasteful and confusing and bewildering, it's also expensive, Public option that if we would fight for that, it doesn't really capture the real savings of single payer. If you think about it, how do we pay for single payer? I mean, how do we make single payer affordable? There are two main ways, as I'm sure you've heard, as I think I've told you, there are two main ways that single payer pays for itself. One is to greatly eliminate the administrative overhead. As you know, the insurance industry, interfacing with the insurance industry and the insurance industry today consume roughly a third of what we spend on healthcare. They've got the, let's say, 15% overhead. And then, as I showed you, they've transferred and hidden another 15 to 20% of overhead to physician and hospital practices. So adding one more layer of complexity doesn't in any way capture the administrative simplicity of single payer. And then the second way that we pay for single payer, of course, is by having negotiating power. Having 330 million or 335 million Americans, it's having somebody negotiate for the price of prescription drugs on behalf of 330 some million Americans, having somebody negotiate for all of us on behalf of all the things that we purchase. Public option wouldn't have that, right? Public option would be one more piece of insurance. It wouldn't have that kind of negotiating power. So you don't get the administrative savings, you don't get the negotiating power. So it doesn't get the real savings. That is one of the reasons that the country desperately needs to get to a more efficient healthcare system. Another big risk of a public option, depending on how it's set up, is that the insurance industry could really thrive on there being a public option. The insurance industry could do massive cherry picking, as I'm sure you've heard about. So in other words, the insurance industry could even more try to attract only the healthy patients and could put in systems even more to make the expensive high-risk patients choose the public option. How would they do that? They would do that by things that they're doing today. They would do that by not including the tertiary care centers, not including or making it difficult to get access to the expensive pharmacologic agents. They could do it by really prior authorizing and putting in barriers to care for the sickest of people and not doing the things that sick people desperately want to have and need to have. The more of those things they put in, the more people would say, that's crummy. I'm going to go into the public option where I don't have those kinds of barriers, depending on how it's set up. And so the more and more that that would happen, the more the public option would become expensive. And therefore, the more the country would point to, hey, we tried a public option. It was outrageously expensive because the government doesn't know how to run things. That's not what that meant. It meant that the industry knew how to leverage their niche and devolve and force the public option into becoming a high risk pool. So if it's going to become a high risk pool, it's not going to be able to survive. Every time we've done a high risk pool in our country, every time we've tried that in states or federally, those have always become outrageously expensive. And then they've also become marginalized because they don't have the power of 330 some million people pushing to preserve and protect the program. Instead, we've got that's just the program for the poor. That's just the program for the desperately sick. That's not the program for me. Sure, I care about it, but I really care about my program. So the more you marginalize and fractionate things, the worse they tend to become, the less sustainable they tend to be. So devolving into a higher risk pool, depending on how it's set up, is a recipe for the thing to be a complete disaster and failure. And then that would tell the country that the government doesn't know how to run a health insurance program, and it could set single payer back even further. So devolving into a high risk pool is a big challenge to pursuing this strategy. What does it do for people that have insurance, but it's crummy insurance? It doesn't do anything. Adding a public option, depending on how you set it up, doesn't do anything to actually improve the people that have healthcare, or the people that have these $6,000 or $12,000 deductibles from their employer. A lot of employers have shifted to really crummy insurance, very high cost sharing, so to speak, very high copays, very high deductibles. How does putting a public option into the marketplace help that? It doesn't, adding it to the marketplace, what does that do to people that don't have insurance? That doesn't help. That doesn't help on insurance. And at the end of the day, and I'm going to come back to this, it's just a strategy. PNHP's position, which is pretty defendable by all the challenges I just gave you, is that it would essentially just delay the inevitable push to get to Medicare for all. Think about the timing of this. If we decided to advocate for a public option, it would take, let's say, what, 3, 5 years to pass it, to build the political power and enact it. And then if it took as long as the ACA and most health reform plans, it would take, let's say, 2 years to become live. So now we're looking at 5 to 7 years. You'd have to run it for, let's say, 2 to 5 years before you could start to assess whether it was actually accomplishing your goals. So you're looking at 10 years. If we were to embark on the pathway of going to a public option as our advocacy target, you're looking at a 10-year process, at the end of which, based on all the challenges I just spelled out for you, at the end of which we'd still have to do Medicare for all. So why would you do this? Why would you embark on this? Well, as you imagine, given what I told you, I think there are ways to mitigate those risks, but those ways aren't simple. So, and that's where this becomes a topic for discussion. I'm going to present to you what I think are reasonable risk mitigation strategies, and then sort of a checklist to look at, and then we'll look at it. Being blurred as single payer, the opposition, that problem disappears largely as soon as it becomes law, right? Once it becomes law and once it becomes live, the ACA was very unpopular until it became live. Once people had it in their lives, all of a sudden they loved it, and all of a sudden it's, keep your government hands off of my Obamacare sort of comments. So once it's up, it's sort of a speed bump, but once it's up and running, it works. The complexity, adding one more choice, that's a fundamental design flaw. A few of the savings, you could capture some of those savings, the administrative savings, if it's publicly run. So there are ways to make it capture some of those savings. If you ran it like most public programs do, the administrative overhead would go down to maybe 2% like Medicare's is, instead of the 15% that the insurance industry is. So you could capture some of the savings of a single payer if you set it up properly. Devolving into a high risk pool, that's one of the biggest hazards of going down this road. And we'll talk about strategies to mitigate that. But the key to prevent it from devolving into a high risk pool is having it be large and not small. And I'll tell you how we could make that happen. Little help for the underinsured. Make it available to the underinsured. Set it up so that anybody who wants it could get it. Set it up so that employers who wanted to get out of the health insurance benefit provision business could simply start paying for your benefit into the public option. Make it so that if an employee's employer is not emphasizing that, let the employee demand that they can go into the public option, and let's set it up so that employees can direct their employer to pay that premium that of course it would have to have. So set it up so that anybody who's underinsured today could one way or another switch into this. The uninsured, there's again strategies for that we're going to get to, but there are behavioral economics strategies that we will unpack that I think can make roughly 85% of today's uninsured accept it as a model. So I believe this could go a long way towards mitigating uninsured, and we'll talk about that more. Delaying the inevitable. Remember, as I mentioned to you earlier, Teddy Roosevelt campaigned on universal health care in the year 1912. So this is not an issue that began last Tuesday. We've been trying to get to universal health care for a long time. And if it were true that the public option is the pathway to get to Medicare for all or single payer, then the sooner we start down this pathway, the sooner we finish this pathway, and the sooner we get that road paved. So can't finish before you start. So what would a good public option be? And this is where the juice is. There are better and worse ways to set up a public option. And I submit to you that that would be the most important thing about a public option proposal, is that it be a good one and not a bad one. So a good one has three key characteristics. The first is a good public option must be strongly tied to Medicare. Strongly tied to Medicare. That means not tied to Medicare Advantage. We don't want United Healthcare running the public option, much as United Healthcare would probably be delighted to do that, or Centene, since they're looking for business right now. So it would have to be strongly tied to traditional Medicare. And that means that it would have to be able to use Medicare's full national network, not a state-based program. That means that physicians would have to, if the physician wanted to accept traditional Medicare or Medicare, a physician would also have to accept the public option. Physician could choose not to accept either, but a physician who wants to play in Medicare would have to also play in the public option. Or likewise, a physician who accepted the public option would have to also accept Medicare. So physicians and hospitals would have to accept both or neither. No gun to your head, nobody compelling you to take Medicare. I know good, terrific physicians who don't, but you would have to accept both or neither, as would hospitals. That would result in those administrative savings I was talking about, one national network. That would result in terrific choice. That would result in a nice program in some ways. One of the biggest problems with commercial insurance, it would get rid of the network issues, and it would capture some of the savings because of the administrative simplicity that traditional Medicare enjoys. National Medicare, not state-based Medicaid programs. So a good public option would need to be for the country. It would not be best if it were designed to be states making Medicaid the program that's available to everybody. There are proposals to have states make their Medicaid program open to the entire state. That doesn't get anywhere near as far along the road as what we would want to do. So I'm not saying that states shouldn't do that to their Medicaid program. I'm just saying a state that offers a state-specific Medicaid for all option is not doing what we're talking about here. So the second criteria, first, strongly tied to Medicare. Second criteria is needs to be better than Medicare is today. So if there's room to negotiate about these three criteria I'm spelling out to you, this is the one where I think there's more room to negotiate. This is the one where I think there's a better and worse version, but it's not as mission critical to get every one of the things I'm going to say here. But ideally, a best case public option would be better than traditional Medicare is today, and that means expand the benefits. A good public option would include all of the missing benefits from Medicare that we've talked about in the past with you. So include those benefits. You really kind of need to include these because some of these are included in commercial insurance today. And if you don't include them, then you're making something that's worse than what's available commercially. So the ideal public option would include all of these things. Would an ideal public option have to include dentistry? Most commercial insurance doesn't. So, that kind of thing is where maybe you could negotiate about whether or not you need all these criteria. But best case scenario, the best case public option would be better than Medicare in this way. It would also be better than Medicare in not having copays and not having deductibles. And then the issues of, well, do you have to buy Medigap if you have the public option? Because is there going to be, so that would not be an issue, and as there is today in traditional Medicare. So the best case public option would not have copays and would not have deductibles. And again, the reason that's so important is because those things are simply barriers to healthcare that are particularly bad for the people who need them the most. The sicker you are, the more healthcare you need to get, the more egregious and unbearable copays and deductibles are. The lower income you are, the worse it is having copays and deductibles. The wealthiest and the healthiest don't care about this issue. So you're designing a healthcare system for the people who need a healthcare system. So copays and deductibles is a really important issue to consider when you're designing a system. And the best case public option would have no copays or deductibles. Again, negotiable. Do you put in a $5 copay? Do you put in something? The more you would compromise on this point, the worse it would be. But the best case would be no copays or deductibles. And then, of course, it would be premium based. We're adding a program if it's not going to be tax funded, which is not baked into the notion of a public option. Public option is not being proposed as something that's tax funded. Instead, it would be premium funded. So you would have to structure it in a way that you could provide premium subsidies for people who couldn't afford however you set up the premiums. So premium subsidies, again, that would be better than Medicare today. And then here's really the secret sauce that I think is not terribly negotiable. And if you don't do these things, it would be a high risk pool and it would become expensive and it would be doomed to failure. These are also some of the more difficult things to do. But these are, I think, some of the most important. You need strategies in the design of a public option to make it start large and be able to grow further. So starting large means some of what I said. Let any individual who wants to be into it go into it. If you're uninsured, you can go into it. If you're employed and have insurance, but you don't like that insurance, you can go into it. And you can compel your employer to pay the premium for that instead of on a par basis, the same premium that they pay for their commercial insurance, they would have to be able to kick in for your public option insurance. That's not an easy lift because if the employer starts fragmenting their employees into some they're paying premiums to the government to run their public option, and some they're putting into the commercial insurance, that means they have fewer employees for whom they're paying for commercial insurance premiums, and the insurance industry typically charges more for the lower level of predictability they get when they insure a smaller population. So that might drive their premiums up for their commercial insurance, or it might drive their premiums down for their commercial insurance because, as I said, the insurance industry would try to drive people who are sicker into the public option. So it's difficult to predict what would happen to an employer's premium. It's not a cakewalk to say what I said about let employers just pay the same premium. But the ideal public option would work that out and would come up with a way for people who are employed and have employer-based insurance to be able to switch into the public option if that's what they prefer. Also, to let it start big and grow, and of course, I don't know if I quite said it, but let an employer decide I'm sick of negotiating with brokers to pay for a health insurance premium every 2 years or whatever it is for my employees. I want to get out of that business. I'm just going to go into the straight, predictable national program of a public option. If you work for me and you want health insurance, the way I provide it is I pay for the public option. So let employers move their whole book of business. And that by itself would make it big, because there'd be a lot of employers who would say, let me out. I'm glad. And not every state is terribly thrilled about running their own state Medicaid program. So let states opt in to the public option as the way that they do Medicaid. Let them instead fund the public option for their current Medicaid population. Um, if you did that, you'd have to be sure that the public option included the benefits that are currently a little bit more generous in most states' Medicaid programs, because the Medicaid population has certain needs that the general population doesn't need quite as much, like transportation. So there are things you'd have to do to make sure that that could happen. But let states migrate their business away from managing their state program with all the headaches that is, and let them just get out of it and do it and put their entire Medicaid population into that. But here's the most controversial one, which I believe we could mitigate, and that is let the entire uninsured population in the country be automatically enrolled into this program. Automatically enroll everybody in the country who does not have insurance into this program. So critics are yelling, mandate, mandate, nanny state, and they're saying, you can't force me into that. Well, no, you wouldn't be forced into that. The key to being able to auto enroll all of the uninsured is to let anybody who doesn't like that notion opt out of it. Let them opt out. Have a really easy, system for opting out of it. So we know, this has not been done. So, it's speculation, but behavioral economists have studied auto enrollment with opting out in a variety of programs. So the one that I've looked at the most closely is on retirement savings. Employers often will match an employee's contribution to a retirement fund. So up to maybe, let's say, 6%. So if an employee contributes 3% of their salary into a retirement fund, a tax-free, tax-deferred retirement fund, some employers try to attract employees by matching that contribution up to usually 6%. So when that was first developed, nobody took it up. When that was first offered as a retirement strategy, you can contribute to this retirement strategy, and we will match your contribution up to 6%. 15% of employees around the country where this was offered, 15% adopted these retirement savings. So then smart investment companies started creating this model instead of, let's propose automatically enrolling your employees in this retirement fund. So tell them what they're going to get paid, or negotiate what they're going to get paid, and then say we're automatically deferring 2%, 5%, up to whatever you want. We're automatically deferring, let's say 3% of what we would be paying you. We're going to not pay you that, and instead we're going to pump that into this retirement fund, and we're going to match that for you. If you're putting in 3%, we'll put dollar for dollar up to whatever that is into this retirement fund. And if you don't like that, if you don't think that you want to actually be investing in your retirement fund because you so desperately need the salary that we've negotiated, that's fine. You don't have to do this. You can opt out. Just check this box, and you've opted out. No pressure. You don't have to do it. So this auto enrollment into retirement funds shifted use of these matching retirement funds from 15% to 85%. It went from 15% to 85% adoption. Roughly 15% of people actually did opt out. So what that tells you is the power of inertia. This is what behavioral economists talk about, just resistance to change. People don't initiate doing this. People don't sign up for these things, and people don't focus on it. I don't know. They don't spend the time or work on opting out. Once they realize what they've got, they go, it's fine. It's fine. And they don't opt out. But those who want to can. So I'm saying that's a really good strategy to apply here, because we desperately need a public option to be large and able to continue to grow. And this would do those things. This would make it large and able to continue to grow, have auto enroll all of the uninsured and let them opt out. So these are the three criteria to roll that back up. These are the three key criteria to a good public option. Strongly tied to Medicare, better than Medicare is today, and start big and be able to keep growing. That's the key. So the reason it's important, I think, to have those nice, simple, high-level summaries is because there's a bunch of versions of the public option, and I'm going to show you one in some detail, but there's a bunch of versions of this, and I don't know which one's going to get traction in 2015, 2025, but somebody's will. There will be a version of this that's going to be gaining traction again. And I think when it does, it's important for you to be able to look at it and go, not only do I not like the whole idea, but here are six specific reasons why it's a terrible idea. This particular bill is terrible. So I think it's important for you to have this schema so that you can look at bills as they go forward. So, as I mentioned, this was introduced originally in 2001. In 2008, most of the major Democratic presidential candidates, and indeed in lower offices too, included some form of a public option in what they were proposing. You heard Medicare for all who want it. There were all kinds of versions of this being promulgated. In 2010, as I mentioned, thanks to Senator Lieberman, it had been included in early drafts of the Affordable Care Act. It was part of what they were proposing. It was part of Obama's plan to get to universal care, and Senator Lieberman killed it. And indeed, had the Democrats persisted in requiring the public option be included in the ACA, it's entirely clear that the ACA itself would not have become law. So that's sort of how this evolved. And then it became quiet for a little while. And then by 2020, it became part of the Democratic Party platform. It was literally in the platform for the party. And just 2 years ago, there were a number of bills that were filed with it. And this year, we're anticipating that there will be some filed again. So the politics have shifted. 2020 Democratic Party platform said, quote, low-income Americans will be automatically enrolled in the public option at zero cost to them, although they can choose to opt out at any time. It's almost like they saw my slides, or maybe it's vice versa. But that's what the Democratic Party said back then. Candidate Biden ran on a public option in 2020. He said he supports the idea of a publicly run plan using Medicare rates. Again, not dissimilar to what I said, available to anyone. He didn't get very granular. He said that though, and he said that this would have higher out-of-pocket costs than most employer plans, and therefore he wasn't a huge fan, but he did support it at some level. And then he became president, and he never again said the words public option. He never said the words public option while he was in office. So politics shifted. And today's Democratic Party, the current party, they put about a platform every 4 years. So today's Democratic Party is radio silent on the idea of a public option at all. But there may be more bills filed in 2025. And no, that's not right. There isn't a 2026 platform. That should have said 2028. Sorry for that. So in 2019, there were a number of bills. There was a Medicare buy-in for older adults that came by two different flavors. There was a Medicaid buy-in that had one flavor. There was the State-Based Universal Health Care Act, which was just reintroduced again yesterday, I think. So there was this state-based approach that I know you heard from several people about, and I'm not gonna unpack that at all until we get to the, what do you want to do kind of part of this. And then there was a Medicare for America Act that was a public program with opting out, the public plan options, of which there were a whole wealth of them. This is going back now 6 years. The most recent data last year, there were these. There were the Medicare Buy-in and Healthcare Stabilization Act, which I've not heard much about. No, that is probably going to be reintroduced this year. The State Public Option Act, I don't know where that stands for this year. We know that the SBUCA, the State-Based Universal Health Care Act, was just reintroduced, and the Medicare X Choice Act, because Democrats really know how to name things. Medicare X Choice Act. Whoever they paid for marketing, they did. Anyway, that one am pretty confident is going to be reintroduced again this year. And that's the one that we're going to talk about. So Senator Kane's office actually reached out to PNHP a few months ago. So we're gonna talk about that one a little bit more because I'm pretty confident that that one's going to be reintroduced this year. So first criteria, is it strongly tied to Medicare? Second criteria, is it better than Medicare is today? And third criteria, can it start big and grow? So strongly tied to Medicare. Unclear. It calls it a publicly administered plan sold on the marketplaces. So maybe using Medicare. It does say it can use Medicare's contracts, but it also says that Medicare that it can use new entities to do the contracting. It does say that providers are required to accept Medicare X at the traditional Medicare rates. So kinda, not perfect, but kinda. Is it better? It says it covers all of the essential health benefits of a qualified health plan plus free primary care. So the benefits are pretty good. Benefits are pretty good. But it isn't as robust as what I spelled out. It directs CMS to do a comprehensive study on other services. And we know that's sort of, the wasteland for programs to advance. You don't want to do something, just we'll do a study, but it tells them to do it. It does have graduated incomes rather than so it has graduated incomes up to 8.5%, somewhat akin to Part B premiums, but not exactly. So I don't know, better or worse. A little more complicated than what we would propose. It's got four actuarial, gold, silver, bronze, cardboard, like the ACA does. So four actuarial, it's a little more complicated than what you might want. And it explicitly includes some of the stuff that a lot of us are not really terribly happy about. The value-based payments and the affordable and the accountable care organizations and all that explicitly carves them in. Whereas, the Medicare for All bills explicitly carve those out and say that we're not going to do those things. As I mentioned to you yesterday, whether that should remain something that's carved out forever, I have mixed feelings on it, but certainly the single payer community in general thinks that those are dreadful, horrible ideas. And the fact that Medicare X Choice Act explicitly includes those are things for which the single payer community is not enamored with. Start big, gradual growth, gradual expansion into certain selected areas. They do talk about offering it in some of the ways that we talked about, but they do not talk about auto-enrolling. They do not talk about transferring of Medicaid plans, and there's no talk in the bills, this bill about employer opt-in. So I'd say that means that there's more risk of this devolving into a high risk pool than we might want to be taking on a strategy that we would embark on. But it's some of the stuff. It's some of the stuff. So that's me blathering on for 40 minutes. So the question for you is, what do you think? What do you think our strategy should be? Should we drop all this stuff? Should we drop the Sabuca approach? Should we forget about that? Should we drop the public option approach, or should we go straight to a single payer and that's the only thing? As I think I mentioned to you, PNHP's philosophy for many years was that you can only cross a chasm in one leap. And my philosophy, frankly, and I think the emerging PNHP philosophy is that we've looked at the bottom of those chasms and there's dead people down there who tried to jump across, and we actually need a strategic plan to get across. So, but, ultimately we have to go there. We need to get there to get to what we want. So should we forget those other incremental approaches? Forget incrementalism because they often delay things. They're incremental, and that means that they're great opportunities for people to be fractionated and excluded. So should we not go down those roads and just go straight and only fight for single payer without any of these incremental approaches? Or should we try to get there by this transition with a public option? And I should point out that the single payer bills actually have a public option built into them. The one bill is 2 years transition, the other bill is a 4-year transition, and both of those bills have, during those transition periods, a public option very similar to what I described. The difference being that those public options disappear at the 2 and 4 year mark because then you have single payer. But, should we start rather than start with the single payer bill that has the public option? Should we start with the public option and then when we get that fully cooked and fully baked, move to the single payer? So should we do this bridge that I'm sort of suggesting to you? Should we not do any of this stuff and focus instead on state-based solutions, as I know you heard about a few days ago? Or, you know, you guys, do you have other ideas? What are you thinking? So that takes us to wanting to hear from you. And I'm not teasing about that. I honestly want your thoughts. I want your thoughts about what I said. I want your thoughts about what you're thinking that don't have anything to do with what I said. Speak up. Lauren.
Yeah, I didn't know about the public option before your talk, so I thought that was really interesting. And hearing about it now and also hearing from the people who are pushing for state based care, I feel personally that I think a public option may be more of a better bridge to leading towards like national healthcare because it'll already be technically a national umbrella. So and also given the amount of time it's been taking to get people to even want to consider a national care plan, I think for Americans, a public option might be like a way to ease into it. And then once people start to see how it can benefit others, they might be more open to um, a single payer healthcare plan.
Yeah, I thank you. Obviously, I agree with you. The marketers tell you provide the satisfier. So they'll often, if they're selling baby care, prenatal care, they'll often put up a picture of a baby, or they'll put a satisfied somebody eating who's very happy with their food. Provide the satisfier, and that sells things. So indeed, making a satisfied population with the public option, I think if it's done well, I think it would grow, and I think it would do what you just said. Um, so, but disagree with me if you know that. And Natalia, you're next.
Yeah, thank you. Um, like Lauren, I hadn't really heard about the public option before, or at least I didn't understand what it was when I did hear about it. So thank you for sharing all of that information. Um, I think my gut reaction, both to public option and to state-based solutions, is smaller things do tend to be more achievable sooner, and people need care now. They don't need care in the future when we can like achieve Medicare for all, which like will we even get there? I hope so, but that might be a long time. And so I guess like my reaction is always, well, get people care now however you can. Your state is responsible for its citizens. If we can have a public option, that's great. My question, obviously, like like you said, there are drawbacks, and I understand those as well. But I think like the people come first in my mind. My question is also it's not static. Like if we don't start doing something, things will still change and we'll still have to adjust our plans and keep making new plans for getting Medicare for all. So just because it's not what we have now doesn't mean we can't kind of keep changing things. But anyway, my question for you also is would state-based solutions and a public option be mutually exclusive in any way, or could those kind of both be happening concurrently?
Well, that's a really interesting question. That's a really interesting question. It would depend on how each of those are set up, right? I can't think of a technical statutory reason why those couldn't happen simultaneously. I can only think of a logistic issue that what would the interface be like if a state had a state-based universal plan with those? I guess you would have to then exclude those states from the national public option, I would think, or set those up to compete. I mean, I don't know. That would be a question that have to be resolved. There's no reason the two laws couldn't be enacted, but you would have to sort out in a state that passed state-based universal health care, does that include or exclude the option of being in the federal public option? That's a really interesting question, and I don't think there's an answer. It would depend. There would be a decision one would have to make. I really like something you said. People come first. There's a variety of ways to make that sort of statement, care before cost, or there's a variety of ways to frame what you said, but that was a really clear, succinct way. People come first. Um, and there's absolutely, I mean, I could not agree with you more about the need to multi-track. You know, for example, right now we're in this huge crisis about Medicaid, that's going to be a growing crisis over the next 2 years. And I don't know if you've heard, but some of the Republicans are talking about having another reconciliation style bill this year to make the cuts to Medicaid even worse. So, um, so yeah, we need to multi-track and focus on protecting what we have, expanding what we have, simultaneously thinking long-term about what's a better national strategy. So, fighting to protect Medicaid in no way is inconsistent with what I was just describing, or the state-based approach. And I talked a little bit yesterday about, you know, why PNHP is developing this sort of multifunctional collaboration, you know, process. So yes, good question. Okay, for the rest of you now, the challenges, those two questions were both really good. So now the bars are, I'm kidding. Ask whatever you like. Serindia. Serindia. How do you pronounce that?
Trinity.
Trinity. It's a beautiful name.
Thank you. So I agree with what Lauren and Natalia said, but I also feel some little bit of like more skepticism that it would be something that would be possible. I do think that doing things incrementally is a smart way to do it because then you, like Natalia said, you're getting somewhere and giving people care that need it now. But at the same time, we've seen how like powerful and strong insurance companies are with their lobbying, and if you do it slowly, I'm worried that, or my concern is that they would come at it faster and it would put an end to any kind of potential good we could do for the future. Like it would put a stop to any kind of future national program that we could have. And I don't know if there's a solution to that or if that's something that I know you touched on it a little bit with the drawbacks of things devolving into of having the higher risk patients fall under the national the Medicare choice program, and then people not being, or that you would have that kind of divide. I don't know, what are your thoughts on that in terms of kind of pushing insurance companies back and not letting them kind of ruin the progress that you could make with something like this?
You're exactly right. I don't know that I have this, you know, a definitive answer to you, because you're right that this is a difficult question that, you know, it's the right question for a strategic decision. I don't know that you know, I don't know the right answer to that. I'll tell you something pretty surprising. One of the encouraging things, if I'm looking for the silver lining, if there is one, about the big beautiful bill, one of the encouraging things is, so I'm looking for a silver lining here, is how fiercely the insurance industry didn't want that bill to pass. Centene, ordinarily considered a very powerful lobbying organization, the largest Medicaid managed care company in the country, and others did not want this bill to pass. And they have a lot of influence, and yet the bill passed. The insurance industry is not happy, and a lot of other insurers are engaged in that too. So the fact that that um, that one of the political parties was able, the political party often considered most sensitive to that kind of pressure, although both are clearly sensitive to it, didn't cave into that. It's pretty interesting to me. But you're right. You know, it's complicated, and need to be thoughtful about that. The insurance industry would hurt it. That was a big risk with the ACA, and indeed they tried. You know, the time gap from when the ACA was passed to when the ACA started to appear in people's lives was a couple of years. And yeah, the insurance industry tried very hard to hurt it during that time, but didn't do enough damage to it that made a substantive difference. So yeah, you're right, Zach. That's that was the driver. Yeah, you're right. Okay, there goes my silver lining. Damn it. Okay. Um, but yeah, I think you're raising the right question for which I don't have a good answer. Mackenzie.
Hi. Yeah, I have a kind of a clarification question with kind of a follow-up comment and question. I think I was a little bit confused on how the public option and Medicaid would interact, if they would completely coexist, if there would be any overlap between them. And then kind of as a follow-up question, I know like the Medicare X bill that you showed us, I think it mentioned like covering very base things, then slowly integrating more complex care. And I was curious about the interplay because I know Medicaid patients can have very complex health issues, so potentially switching to that option wouldn't necessarily be good for them. And if that kind of situation would mitigate the possibility of creating a high risk pool in some way, or I think I'm kind of confused about that.
So I mean, both of those, if I remember them properly, both of those are the Medicare X plus whatever that's called, explicitly does not bring in Medicaid. So states could not move their book of business into that bill. So the issue that that bill doesn't have adequate benefit design to meet the needs of the Medicaid population is not an issue since it's not an option. In the ideal way, in the way that I described to you, what the way a good public option would interact with Medicaid is at the discretion of the state. So a state could completely ignore this and say, we run our Medicaid program, we think we're doing gangbusters, and we want to leave it alone. Would not have to in any way migrate its Medicaid population in, which again gets away from the idea of it being a mandatory, a mandate kind of a thing. But I suspect a number of states would say we are sick and tired of being responsible for the budget, being responsible for managing it, being responsible for negotiating with the MCOs that we've decided to let eat out of our kitchen. We're sick of doing that, and we're happy to simply keep paying what we're paying, but pay it to the federal government so that people can have the what's currently the public offered as a public option instead of having our state-run Medicaid program. If you set it up such that states could do that, what I was saying was that you would have to make that. I was saying your point that you would have to make sure that the benefit design in the public option was robust enough to include the things that Medicaid populations tend to need more intensely than do non-Medicaid populations. And I used transportation to work or to healthcare as one of the examples of that. But there are things that are in Medicaid typically that you would have to make sure you included. Does that mean you would set up sort of a more complicated, have like the straightforward public option and then a public option Medicaid version for the states? Have like two public options going? That creates an administrative expense to having that, to doing it that way. Would that administrative expense be, when you save the administrative expense by having one public option, would that fund expanding the benefits to everybody? I mean, there's an arithmetic problem there, but it's a completely valid question for which I don't have a completely valid answer. But yeah, does that help?
Yes, thank you so much. I think I was getting confused.
Well, there was a lot, a lot of information here. Zachary.
Yeah, my last comment would be about like it's more so focused along the lines of like fragmenting progressive support among like different reforms. So we just finished, I think, our country presentations, and every time that a country makes some sort of like universal healthcare program that's public, it's like during a time of insane political upheaval and like disruption. So like in Brazil, it was the fall of a dictatorship. In Germany, it was going to be a socialist uprising and overthrowing of a government, or Otto von Bismarck gets to maintain control. In a lot of European and even South Korea, it was like after World War II, they're rebuilding their country. It's a war-torn country. They're starting from almost scratch. So I think if we start fragmenting between like single payer or public option, like regardless, we're going to be doing this fight for probably our whole life until we get to an event like that. And I'd rather focus on building like solidarity and support around something like Medicare for all, which would be the end goal, because I don't think even a public option would happen unless there was some sort of like cataclysmic event like that I just mentioned. So I'd rather focus on being able to be most prepared for that event and be able to implement it and act efficiently at that time, then start fragmenting support among all these like other things. But I'm not sure if that's a, widespread opinion. I like to focus on history and what people have done before us, but I know that's not always popular.
That's really interesting. Um, and that's a completely reasonable and defensible point of view. The idea of we're not going to probably not going to get either of these things unless something disastrous happens, until something disastrous happens, and then we need to be fully baked and fully ready to go with the thing that we can promote, and that never let a crisis go to waste. Um, and I don't know that that's true. I don't know. Obviously, we don't want to push for single payer explicitly saying, but we're going to wait until something disastrous happens, and we want to push for it as if it's right, as if we could do it tomorrow. But you might well be right that it's politically unrealistic to think we're going to get there until that landscape shifts. So that's a completely reasonable point of view. I would push back and say that the public option, in the way that I described, is less abrupt of a change. It's more akin to the level of change that the ACA introduced. It's more akin to the level of change, not Medicare itself. Medicare itself was enacted at a time when seniors couldn't get health insurance by and large, largely. So it was an extra nice thing. It wasn't so much of a takeaway. But this would be an extra nice thing. This would be if you'd set it up so that it's good. It's, no one forced into it, or till you opt out. No one forced into it. You can do it if you want it. It's an option. So from that point of view, if you market it better than calling it Medicare X plus choice, Jesus, I think it's a way. So I think it's a reasonable point of view. I think your point of view is completely reasonable, and I'm not disagreeing. I'm just, yeah. Marvin, and then I'm going to have to run. You're muted, Marvin. You're on mute.
In general, I guess I kind of side with Zach a little, only because this would take a pretty big lift to get this passed. The
Yes.
same thing with the state-based plan. Do you think that the insurance companies want to have that state-based legislation? So they're going to do all they can to fight that one. And I just feel like so much of the lift already needs to happen. By the way, the disaster that Zach speaks of may in fact be happening with what Trump and the Republicans are doing with Medicaid, because this is not small. I'm amazed how casual our own state government has been about it here, and just like, oh yeah, we're kind of studying it. It's how much study do you need? It's going to be catastrophic. Missouri, how many hospitals are you going to have close in Missouri if this happens? Anyway, whatever. So but I wanted to, and I'm worried that there is so many conditions you're attaching to this to make it pass that it'll be hard to defend each one of those. And each thing you don't defend, you end up with more of a problem. Fewer people in the risk pool, even higher administrative costs. I just worry about that. And finally, I want to ask a question. I don't really understand the proposal in the sense that, it was our PNHP chapter met with the guy who's now Senator Peter Welch here in Vermont. And he was saying, oh, we should just let everybody buy into Medicare. Medicare is really popular. And, and we're kind of taken aback by that. And there's many arguments against that. Not least are the huge deductibles and the 20% co-insurance, that make it a fairly bad coverage. But anyway, nobody mentioned, including him, that the average subsidy from the average amount of money the federal government's paying for Medicare patients is around $16,000 or $17,000, something on that order. And we're already complaining that we don't like our benefit because I have to pay $2,000 for the private thing and $2,000 for Part B premiums. Okay, so now you're taking, and nobody said the federal government is contributing. You said they're not. So these are going to be big, expensive plans with great benefits. Who's paying? I don't get it.
Well, remember, Medicare population is probably 3 times as expensive as the non-Medicare population in terms of actuarial risk. So you're looking at less money to begin with. And, these are things that have to be worked out. The employers would probably be able to fund the program for less than what they have to pay today. Today, they're paying for the profit and overhead of the insurance industry in their premiums. This would probably be significantly less expensive to administer than, I mean, how could it not be less expensive to administer than what they are currently purchasing? So I would think if you set this up in the way I described, many employers would want to switch to this instead of what they're having to do today. Gets them out of the business. So I think the biggest book of business that it would attract is the current employer based. Um,
Mhm.
and I also think states would get a win if they went into it because it would be publicly run, which is we're in the midst of this analysis, but we believe a publicly run program as opposed to the huge managed care penetration that Medicaid has today could probably be at maybe 10% less expensive to administer. So states would probably get a win out of it as well. So I think you would see states be willing to do it, not Missouri. Missouri, anything that says USA on it, Missouri hates. But some states would adopt it, and then they'd create an argument that they got a win, and it would grow that way. I think the biggest issue is the stuff that you and Zach brought up, which is that it fragments and how do you organize around it? This is like, how do you make a political advocacy move around it? It's what's the bumper sticker? I want bread that's sliced better. No, we're not gonna. It's so no. These are things you'd have to think through and maybe be able to resolve. Maybe not. I don't know. And you're exactly right that I just spelled out three large criteria, each of which had maybe three sub criteria under them. And if you really got serious about it, there's probably even more granularity to where this could go wrong. And yeah, the insurance industry would find all of those bits of granularity so that they could keep the three large topics and then just have them be meaningless when you actually get down to the regulatory version of it. So yeah, it's not a slam dunk. Um, I just personally find it hard to see a pathway to single payer that doesn't go right through the public option. I find that hard to see. Unless, as you're right, the Trump disaster that is racing down towards us creates the conditions that Zachary, spelled out as necessary to get us across the chasm. So, and PNHP is absolutely pursuing that as our core mission. So, yeah,
And
I don't know.
I want to
Yeah,
be clear, I do not endorse or condone any sort of like catalyst for those conditions. I think
no.
that it's a yes, am recognizing a pattern in the country presentations.
Yeah, I mean there actually is a very small and not terribly vocal, but very real group that favors it's called accelerationism. There's a word for it. There's a small but pretty marginal group that actually favors letting things get worse so that we can step in with something better. And I think the technical term for that is crazy. Let's try not to let's minimize harm. Let's help people today. Like I think everybody agrees with that. So yeah, cool. I got to run. I got more to do. As you got more speakers coming up, but this was fun. I really enjoyed this discussion. Thank you.
Thank you.
you.
Thank you.